Patient Education Lesson 6. Lesson 6 will help us define the terms compliance, adherence, and motivation and apply them to learning. We will look at strategies that facilitate motivation and improve compliance and adherence, and look at models and theories that predict health behaviors. The first term we will define is compliance, which is the submission or yielding to predetermined goals through regimens prescribed or established by others. It infers that the clinician is the authority and the patient is submissive, but it can be described as, quote, the extent to which a patient's behavior coincides with clinical advice, end quote. Adherence is a commitment or attachment to a prescribed regimen. This suggests that there is patient involvement in the healthcare regimen rather than passively following a provider's prescriptions. Although there is theoretically a difference between adherence and compliance, they are often used interchangeably when measuring health outcomes. The term noncompliance suggests a non-submission or resistance of an individual to follow a prescribed predetermined regimen, but may be a defense mechanism to dealing with a stressful situation. Noncompliance may be related to patient issues such as knowledge or motivation, side effects of treatments, disease issues such as prognosis, lifestyle issues such as transportation, socio-demographic factors such as social and economic status, and psychosocial variables such as depression or fear. When describing compliance or adherence to a treatment regimen, we can observe and measure outcomes that show the patient has cooperated with the plan and/or maintained the regimen. Locus of control refers to an individual's sense of responsibility for his or her own behavior, and the extent to which motivation to take action originates from the individual themselves, internal, or is influenced by others, external. There is mixed research as to whether internal or external influences compliance, noncompliance more. Motivation means to move a person toward action, whether positive or negative. There is a relationship between motivation, learning, and behavior, and we will attempt to address these complex relationships. There are three motivational factors that can either facilitate or block motivation. They are, number one, personal attributes, which consist of physical, developmental, and psychological components of the individual learner, such as age, values and beliefs, educational level, etc. 2. Environmental influences, which include the surroundings and the attitudes of others. And 3. Learner relationship systems, such as those with significant others, family, community, and teacher-learner interaction. Motivational axioms are rules that set the stage for motivation. They include state of optimal anxiety, which states that a moderate amount of anxiety is optimal for learning, learner readiness, which can be influenced by specific incentives relevant to the learner, realistic goal setting, which should be agreed upon between the clinician and patient, learner satisfaction success, which provides motivation to achieve more steps toward a goal, and uncertainty reducing or uncertainty maintaining dialogue, where the patient may self-talk through a problem or outcome. They are cognitive variables, affective variables, physiological variables, experiential variables, environmental variables, and educator-learner relationship system. Cognitive variables include the patient's capacity and readiness to learn as expressed by a patient wanting to move in a certain healthcare direction, such as, quote, I want to take care of myself, and willingness to agree to behavioral changes. Affective variables include expressions of a positive emotional state with a moderate level of anxiety, which is the most conducive to learning. Physiological variables, such as the ability to take a short walk if that is the agreed upon part of a healthcare regimen, and experiential variables such as previous success with a learning activity also influence learning. Lastly, environmental variables include the physical environment and the patient's social support system. Motivational strategies are those designed to increase motivation or decrease obstacles to achieving goals. They generally use incentives which can either be intrinsically or extrinsically generated. Motivational interviewing can be used to enhance motivation and resolve obstacles to change. It involves the Reeds method, which is R, rolling with resistance, E, expressing empathy, A, avoiding argumentation, D, developing discrepancy, and S, supporting self-efficacy. Other strategies include clearly stating directions and expectations, making the information useful, making the environment conducive to learning, providing positive feedback, and providing opportunities for success. In addition to motivational interviewing, the clinician may also observe Maslow's hierarchy of needs, or ARCS model, which suggests that patients will respond to information that grabs their attention, is relevant, inspires confidence, and satisfaction of achievement. Some of the models that can be used to describe, explain, and predict health behaviors of patients are, number 1, health belief model, number 2, health promotion model, 3, self-efficacy theory, and 4, protection motivation theory, 5, stages of change model, 6, theory of reasoned action, and 7, therapeutic alliance model. The health belief model was developed in the 1950s and explains and predicts health behaviors based on the client's beliefs about their health problem and health behaviors. It is comprised of the individual's perceptions, which include perceived susceptibility or perceived severity of disease, modifying factors such as demographic, socio-psychological, and structural variables, and likelihood of action, which is perceived benefits of preventative action minus perceived barriers to preventative action. The health promotion model uses approach behaviors rather than avoidance of disease behaviors as a guide to how likely a person will engage in health-promoting tasks. It consists of individual characteristics and experiences, particularly prior behavior and personal factors, behavior-specific cognitions and effect, which are perceived benefits of action, perceived barriers to action, perceived self-efficacy, activity-related affect, interpersonal influences and situational influences, and lastly, behavioral outcome, which consists of health-promoting behavior. Self-efficacy theory looks at the patient's expectations relative to a specific course of action. It is based on 4 principles, including performance accomplishments as evidenced by self-mastery of similarly expected behaviors, vicarious experiences, such as observing successful expected behavior through the modeling of others, and emotional arousal through self-judgment of physiological states of distress. It is useful in predicting participation in healthy behaviors. Stages of change model, also known as the trans-theoretical model, encompasses distinct time-related stages of change. They are pre-contemplation, where the individual has no current intention to change; the contemplation stage, where the individual accepts that they have a problem that needs to change; preparation, where there is an active plan to change; action, where there is a visible modification of behavior; maintenance, where the action must be maintained and is often the most difficult stage; and termination, where the problem no longer presents a temptation. Theory of reasoned action looks at behavior within a social context and consists of an individual's beliefs, attitudes and norms, intentions, and ultimately their behavior. Lastly, the therapeutic alliance model addresses the shift in power from the clinician to a collaboration with the patient. It looks at compliance and adherence, which may begin as a dependent conforming relationship on the patient's part, to an alliance where the clinician and patient collaborate on a plan of self-care.